Okay, it's 2:02 now, and we're going to start promptly. Good afternoon, everyone. Welcome, and thank you for joining us today. I think I've met all of you last week, but for those that haven't met me, my name is Estefania Rubio. I am the data manager for the FPQC. In my team, I have Benjamin Gessner and Shelby Davenport. They are also part of the data team. So anything that is data related, we're going to be here to support you during the next 18 months that the initiative is going to last. We are extremely thankful and excited that you have decided to join Homeward Bound. There is so much need and there is so many opportunities that we have identified that we can definitely make a huge impact and a big change in the state for the way that our babies are being discharged from the NICU. So today we are going to focus on the data. So just a couple reminders, very brief housekeeping. Make sure that you have muted yourself. If you have questions, please enter them in the chat or raise your hand and we'll ask you to unmute yourself. We'd love to have questions and interactions and your thoughts and concerns. So please keep it interactive. We'd love to hear from you. Participate in either way. The webinar is being recorded and will be shared in our YouTube channel, and it will be available for others in your team that haven't been able to attend today. So hopefully by now you've seen this many times and you know it by heart. This needs to be part of your elevator pitch, right? Why are we doing what we're doing and what we're trying to get? So our aim for this initiative is that by June 2025, participating NICUs will achieve a 20% increase in two things: discharge readiness for NICU infants, and also an increase in the completion of the discharge planning tool upon discharge home. For the discharge readiness, we are going to be measuring that by the parental technical readiness checklist completion and the emotional readiness score by patient questionnaire, right? We cannot collect data for baseline prior to starting the initiative because many of the things we're going to ask you to do are going to be new, and you will have these last 3 months before the initiative launches in January in your hospitals to put those processes in place. And so the baseline will actually be established with the first quarter of hospital data. So when you start submitting your data in January for the patients, we will use those first 3 months to establish your baseline, and we will determine the 20% increase on all those key measures from that baseline. Now, this is also something we shared a lot during kickoff. We shared a hard copy of this one as well. This is our theory of change, and we think that if we act on those primary key drivers, we will get to our aim. And so today, you're going to see everything that we are going to be measuring regarding those primary key drivers. And there is a lot of data that we're going to be collecting, but we were extremely intentional to only request that you collect the information that is going to inform the initiative. As this is quality improvement and not research, we just wanted to use the amount of data that was right so we could really track and check that progress is being done. And if it's not, to identify opportunities where we can support you more. So for this initiative, we are going to have 2 types of data: patient level data, which is going to have aggregated social determinants of health data, and also a sample for additional patients that you're going to submit on demographics and SDOH, and also discharge preparedness and emotional readiness assessment. And we're also going to ask that you report hospital level data. So how is your staff training going, your standardized documentation, and the policies and guidelines that you have put in place to support Homeward Bound? So we are going to start with the patient level data. And we are going to use the data collection form that we shared with you at kickoff to go through everything that we are going to be collecting, okay? So the very first thing in that form is the demographics, right? So for our patients, we're going to be looking at the discharge month and discharge year, whether or not the patient was discharged during Saturday, Sunday, or a holiday. We're going to ask you about length of stay, and that's going to, the definition for that is to count if the patient was in bed at midnight. Sue sometimes says how you would count your census. It's kind of the same thing. And you will give us just the number of days that the patient was in the NICU at midnight. We'll ask you about the primary caregiver's preferred language, and that can be English, Spanish, Creole, other, or unknown. The primary caregiver's race, and here we ask you that you check all that apply, and we've given you the main options for Florida, but we know there's many others, so you also have an option for other. So there's Asian, Black, White, other, and also unknown. For primary caregiver, you have Hispanic, non-Hispanic, or unknown. The other one on the infant is going to be gestational age at birth. We ask you that you only report completed weeks. All right. So if it's 37 and 6 days, still keep it at 37. Don't go up, don't round up or down, just do complete weeks. For birth weight, we ask only grams. And again, it's going to be just the complete grams, no decimals, please, on that one. I'm sorry. We're also collecting type of insurance. So you're going to have Medicaid or Medicaid plans because there's so many HMOs now. Private, self-pay, other, or unknown, and whether or not the patient was inborn or not. We always ask about demographics because this informs case composition and helps us track population change over time. We use this to disaggregate measures to identify differences between population groups because we know that there's always gaps in healthcare, right? But when we apply standardized care and we do these quality improvement cycles, we have noticed that those gaps really reduce for those groups. And so it's important that we track them over time to see those gains in there, if not to identify opportunities. The next section in your data form is going to be discharge preparedness. And there's 3 small sections within those. So the first section in that is that we're going to ask you to check all that was documented in the patient's chart. And the first one is going to be if a complete technical readiness checklist was completed, right? So the complete readiness checklist comes from the table 1 of the discharge education that we share with you. These are the guidelines and recommendations that were published last year that are new. It's a huge list. So if you want to use the entire list, you can do so. But efficacy, along with the family advisory and work group, put together a special worksheet that makes it a little more succinct. So we recommend you to use this worksheet. It's in Word right now. It's a Word format, so you can edit anything you want. If you want to add specifics or you want it to be more comprehensive, you can add to it. But the reason why we recommend you to use this one is because the way that we are going to track that this was completed is by checking if the teach back date was recorded, right, was documented. So you're going to have a lot of topics that need to be given to the family. There are a lot of things that need to happen for the family, but there is going to be these sections that say provide discharge teaching on, and then you have topics under that. So for this first example, you can see here that says provide discharge teaching on feeding or nutrition guidelines, bowel or bladder patterns, bathing, skincare, cord care, temperature taking, circumcision care if needed. So under all of those, we're going to ask you to put the date when the education was completed and by whom, so the initials, and then the teach back date. So remember when we were talking about the guidelines, that was what we heard from Dr. Smith, that it was important to either document the demonstration of the skill or the teach back. So that is how, when you collect your data, that's what you will be looking at, whether or not there is a teach back date for those specific items. You can also track family declined, but if the family declined any of the education or the skill training, you will have to add a comment in the list. All right, so the next section is whether or not the infant had a complete discharge planning tool, right? And we have a lot of tools available in the toolbox, in the FAQC website. This is one of the samples that we share with you. So this is one of the documents that we hope you will share with your families. And it needs to be documented that this was completed with the family and the family has copies for them to keep. Now, as I was mentioning, here is the website that you need to go if you want to look for additional examples, or you may already have at your own facility your own discharge planning tool. So if you have one, and it works well, it has all the items that need to have it, then you're welcome to continue using it. But if not, and you need a new one, or maybe you need to update yours, there is a lot of guidance on the toolbox on what elements need to be included in the discharge planning tool. So that is the second item. The third item is to call the pediatrician or the primary caregiver. The primary care provider. And that is for the clinician to clinician handoff, right? That was another one of the things we heard from Dr. Smith and many of our families on how sometimes the pediatrician is going to be clueless because they've never talked to another physician about the condition of the baby. So that was a huge recommendation from the guidelines and also from our parents. So if that call occurred and it's documented in the chart, then you would check that as yes, that happened. The next one is if there was a follow-up phone call within 3 days after discharge. And we know that this varies by NICUs. So this is depending on your NICU unit policy. And again, you're going to find those tools in our toolbox. All right, the next section under discharge preparedness is going to be education. So we're going to be asking you if the primary caregiver received the documents and verbal education on the patient-specific care plan, right? So the first one, you have here the sample of the patient-specific care plan elements that FPQC recommends. In the toolbox, there's also a template. It's a Word template where you can add or you can adjust depending on what your NICU does. But these are the basic elements that we recommend are included in the patient care. And of course, this care plan will be useless unless the family has it. So our big request is that you not only give those documents to the family, but that also you do some verbal education on what's included and how they're going to use it. The next item is the discharge summary, right? So you're going to be telling us if the family received the discharge summary. Again, FPQC has made some recommendations on what needs to be included in that discharge summary. That's again in the toolbox. And there is also a template in Word that you can use to adjust for your NICU. But again, the important thing here is that that discharge summary is complete and that you review it with the family. And so again, we're asking you to provide the document, but also to provide verbal education on that document. Okay, so that was the first section for discharge readiness. The second section is the social determinants of health, or SDOH. In some places, they also call it a health-related social needs. So, you know, it's different lingo. It depends on which one, in which term you're more used to. We are using it interchangeably. And the reason why you see us using more social determinants of health than health-related social needs is because CMS has now a new requirement for hospitals to start reporting a screening in January 2024. And they are using SDOH for that language, you know. So we are using that language to align with the requirements by CMS. So the first thing that they are requiring is that everyone needs to be screened during the admission, right? And so the primary caregiver will have that screening, and that can be positive, negative, the patient can decline, or simply it wasn't documented, right? So you will tell us either one of those. For those patients that had a positive screening, you will have 2 follow-up questions. The first one is on which category they screen positive. Here again, we have 5 categories, and those are the CMS categories that are going to be required starting on January 2024. And that is food insecurity, utility needs, feeling unsafe at home, or interpartner violence, housing instability, transportation needs. And if your hospital is conducting other SDOH and you would like to report it, we are also giving you that option so you can do so, right? But the first 5 are the ones that CMS is requiring. So we are just aligning with that CMS requirement and helping you get a jump start, you know, since this is going to be our requirement since January 2024. The second question that is going to follow up if there is a positive SDOH screening is an action plan, right? So if there was a positive SDOH, what was done? So the first thing is maybe social work consulted, maybe there was a further assessment completed, appropriate resources may have been provided, or appropriate referrals may have been arranged. So you can check all that apply, right? If everything was done, fantastic. If some of those things were done, same, you will just mark whatever was done for that particular patient. We do ask you that for appropriate resources provided, you check that if the resources were provided while the patient was hospitalized, right? So that's the only caveat on that one. The next section is discharge preparedness for appointments, right? So you're going to check all the appointments that were scheduled prior to discharge. And we give you several options, right? So patients should have an appointment scheduled with their primary care provider within 3 days of discharge. They should have all their specialty appointments scheduled, all therapy appointments scheduled. If Healthy Start is part of the care plan, they should be scheduled, as well as early steps or Medicaid managed care. And all their equipment appointments should have been made. And this is just, how we bundle those services. So the families go home with everything already in place, and it's less of a chance that they will miss the appointments. Now we are giving you some options, right? Either the appointment was scheduled, it was not scheduled, maybe the patient declined, or simply it's not applicable, right? In the NICU, you're going to have some variation of patients. So some of those patients may not need therapy, for example. So we will ask you to check not applicable if that's the case for the particular patient. And so again, this is patient specific and based on your unique criteria. Okay, and then the last section of the data form is the emotional readiness assessment. And here, this is something that we will ask the bedside nurse or the personnel to ask 3 questions to the primary caregiver the day of discharge and to document their responses, right? So in the NICU discharge planning worksheet that I shared before that has the technical aspects, at the end of it, there is the 3 questions that we need the nurse or the bedside staff to ask prior to discharge. So the bedside nurse will ask the primary caregiver to rate the following states. So the first one is, I feel confident that my infant's heart rate and breathing are safe. The second one, I feel confident that my infant is developing and growing now. And the third one is, I am ready for my infant to come home. And the options are, maybe not at all confident, somewhat confident, and very confident, right? So at discharge, those 3 questions will be asked, and it's important that they are given the 3 options so they can choose which option they feel they fall under. We do ask you that you document the answers provided by the primary caregiver the first time the assessment is conducted. I imagine if they say, I don't feel confident at all that my infant's heart rate and breathing are safe, your team is going to provide additional education and additional feedback to reassure the parent that that's not the case and that things are going well and that's why they are being discharged. But the idea of the emotional readiness assessment is to get their first impression, right? So maybe if you do the assessment again, you will get better responses, but we want to know their first response. So we are going to ask you to document only the first assessment. Okay, and that's all that is going to be asked in the data collection form for your patients. We do ask you that you collect this information on all your patients, but we understand we could never ask you to submit data on all your patients. So we are going to give you some specifics on what you are going to submit to FPQC as part of participation with the initiative. The first one is inclusion and exclusion criteria, right? We ask you that you only include those infants that had a minimal 2-day stay and who are discharged home, right? So if they had less than a 2-day stay, it was most likely just observation. You don't need to include those infants in the data collection. And if they were discharged and if they died or were discharged to another hospital for escalation of care, again, you do not need to include those infants. You're only including infants that had a minimum 2-day of stay and are discharged home. The second thing is we are going to only report a small number of infants, right? We're not going to ask you for all your infants. We would never do that. But we are asking you for a sample of up to 20 infants. So we ask that you report up to 5 infants for each birth weight category. So when you prepare your data for reporting, right, you're going to have your census and you're going to have to distribute your patients by the birth weight category. And these are the groupings, right? So 2,500 grams and above, 24.99 to 1,500 grams, 14.99 to 750 grams, and less than 750 grams. Many of you are not going to have enough patients in this category, right? In the lower category. And that's completely fine. You will either report as many as you have, or you will just not report any if that's the case. So you will report every month up to 20 eligible patients. It may be less depending on your particular circumstance. And another caveat, at the beginning of the initiative, your hospital has the option to opt out of reporting information on smaller birth weight categories if the number of infants in a specific category is consistently less than 5 per quarter. So we know that smaller units or maybe level 2 NICU units will not have enough patients in a specific category. So this is specifically for them. So if that's your case, you will have to report to us that you have 2 little patients per quarter in a specific category, and you will simply opt out of that category. And you will only report on those where you have stable numbers. So for the sampling selection, if a category has more than 10 discharges in the month, you're going to report the first discharge on each weekday for the first 4 weeks, and then the first weekend discharge. And the reason we do that is we want to know how the discharge process is going in your hospital throughout the month, not only for a couple of shifts or not only for the first couple of days. So that's why we're not asking you for the first 5. We're asking you to give us 1 infant per weekday, per week for only weekdays, and then the first weekend discharge, so up to 5. So just a quick example. If Hospital X has 17 deliveries with a birth weight of 1,500 to 24.99 grams, the reporting will include the first discharge on a weekday in the first, second, third, and fourth week, as well as the first weekend discharge, right? So just up to 5. If in a category you have less than 10 discharges in the month, then yes, we're going to ask you to just report the first 5 discharges or as many as you have, right? And again, the idea is that if you have less than 10 discharges in a month and there's a specific category, most likely they're going to be throughout the month and not just the first couple of days. So again, the idea here is to have representation of the discharge process throughout the month. Okay, I want to stop here for a second because I know that this can be confusing. This is a new process for us, and I want to hear from you. What questions you have? Is this clear? Is this confusing? Anything that we can do to help this idea be better understood? Please let me know. If you can unmute yourself and just ask your questions, or you can use the chat box to drop your questions.
Hey, Estefania, it's Claire from Joe DiMaggio.
Okay.
It just seems very overwhelming, I'll to be honest. There's a lot of variables with multiple people being involved, parents. We have a navigation program that helps discharge preparedness, like you said, a parent survey, then going and backtracking the discharges in those different weight categories. It just really seems like a lot, just from honest feedback. I can't even process how we're gonna go about collecting all of this.
Right. No, and I appreciate your feedback, Claire. I completely understand. So if we go by steps, the first step I'm going to ask you to do is to review that data form, right? The data collection form for the patient. And, we know that discharge is comprehensive and there's a lot of sections that are going to happen, and we know there's a lot of steps. But for the data collection side, that's the very first thing that I'm going to ask you to do, and then highlight what you don't do, because a lot of those things you already do. Yeah, from what we've heard in the advisory committees, many of those things are already in place in many of your NICUs. So what we're going to do is standardize the process, make sure that every single patient gets it. But many of you already do that, at least for a good amount of patients. So that would be my first request. Look at the data collection form, go through each one of those elements, and highlight the things that you definitely don't do. Once you have that in place, then you will need to build those things or have a paper form to collect it. And that is difficult, we completely understand, but that is part of the implementation of the new initiative. On the data side, I know that I'm giving you a lot of variables. I will share with you a document that has very clear instructions. So right now, I completely understand. It seems like a lot. We wanted to make sure that we are looking at a good number of patients for each category. That's why there is so many things, right? If we ask you to give us just the first 20 or the first 10, the risk was that we were just going to be looking at the first couple of days of discharge and maybe just a couple of your teams. And the idea is not just to look at one specific team, but to look at what is going on throughout the month. And for the weights, the birth weights, you know, when we discussed this with the advisory committee, the recommendation was to make the categories so we could see those processes being done for all the infants, because sometimes those are only in place for very small, for the extreme low birth weight infants. And, you know, those infants with better birth weights may be slipping through the cracks. So that's why we are going through a lot of categories, but I will provide this in a specific detail, and I will help you at the beginning to set up those groups and to set up exactly what you need to report. I'm sorry that it feels overwhelming. I completely understand, but hopefully if we do it step by step, we will be able to answer all your questions, because I'm sure there's going to be a lot of questions once you start doing it. And then for the data submission, we will be, you know, helping you to set up those categories at the beginning if needed. But the biggest idea here is, you know, to just get a good idea of what's going on throughout the month and by each patient group, right? So we have the normal weight babies, the lower weight, and then the extreme weight.
How many months are we collecting data for?
We are doing from January to May of the following year. So that is 17 months.
Okay.
The total initiative is 18 months.
Stephanie, this is Giselle from Winter Park. I just wanted to clarify for a level 2 NICU that will only usually be in the first and second weight category. So will that be a total of 10 for the month?
Yes.
Okay, so it's not like we have to do 20 total, just 5 from each category. And if it's less than 20, it's less than 20.
Yes, absolutely right. Now, the request is that you have less than 5 per quarter. Now, if you do have, let's say in this one, right, the 1499 to 750 grams, if you have at least 5 per quarter, we ask you that you submit as many as you have, right, per month. But if you have less than 5 consistently per quarter, then yes, you can opt out. You can just say, okay, I don't have enough, and you don't have to report on those categories.
Stephanie, this is Sue. We have a couple of questions in the chat.
Please do. Yes, please. Thank you.
So on the first one from Beth Ann, are we including only inborn infants, or are we going to include transfer in as well?
You can include transfers in if they are going home when you discharge them, right?
Right. And as long as they
send them back, then no.
And if they meet the criteria of the 2 days, right?
Right.
And then the
Absolutely
2 days again is midnight census. So what your midnight census would be is how you do your 2 days.
Correct.
Correct?
That is correct.
Okay, and then so to clarify, Adrian asked, if possible, we will include a discharge from each week in a month, plus one discharge on a weekend, correct?
Yes,
Okay.
one per weekday for the first 4 weeks and then one in the weekend. Perfect.
And then Catherine asked, can you pick the day of the week?
You don't have to, it's the first discharge on a weekday. So
Okay,
if it happened on Monday, it's Monday. If it happened on Tuesday, it's Tuesday. It's just the first weekday.
okay. I think that's all the questions that we had in the chat box.
Perfect. Okay, we'll move on. But if you have any other questions, please don't hesitate to drop in the chat box or come out of mute. This is great. Okay, so we went through the sampling selection process, right? So once you identify those infants that you need to report on, we ask that you complete that data collection form for that particular patient, right? The very first thing that you're going to see in the data collection form is this study ID number. And we ask that you assign a study ID number. We never get medical record numbers for patients. We don't get a lot of identifiers. We mostly don't get any identifiers. So we need that study ID. So if we have questions, we can call you and you can, then connect that study ID to the medical record number and you can tell us what we are asking you for. Or if you need to make any corrections in the record, you know which study ID you need to correct. So it's very important that you start to assign those study IDs. And we ask that you start in 001 for the first patient and then add consecutively for all the patients that are going to be submitted to FPQC throughout the initiative. We ask you to keep track of your cases. So we give you this log, it's just a template, right? Where we ask you to put the medical record number, the study ID for that particular patient, the survey return code that you're going to get once you submit the data, and who collected the information, right? This is something that we ask you to keep internally that is just for you so you can connect those patients. This is never to be sent to FPQC. This is just for you and your team. It's also very nice when you have an abstractor that leaves or a data lead that needs to be changed, then it's very nice, something that you can hand off to the next person and it's all organized in one place. So for the process, once you identify your cases, again, if you have a category that has 10 or more, you're going to select those 5 infants systematically. And then if you have less than 10, you're just going to give us the first 5 or as many as you have. Once you identify those babies, you're going to abstract their medical record using the data collection form that we have given to you. And once you have all those completed, we ask you to enter that data in the REDCap portal. So the link will be shared with your project and data lead once the data user agreement is fully executed. So it's very, very important that you track the completion of your data user agreement. The other thing I mentioned to you for the patient level data is that we're going to collect aggregate SDOH information, right? So in the back of the data form, you're going to see this table. And so here it says number of eligible infants discharged home. That's an easy one. The next one is number of eligible infants whose primary caregivers had an SDOH screening documented using an SDOH screening tool. So here you're just going to give us the total number. This is just aggregate. And we give you the option to say unknown because we know that even though this is going to be required by CMS starting on January 1st, many places still are not screening universally. If your maternity unit is working on the Mother Focused Care Initiative, you have a huge advantage because they are already working on doing this and they already know how to document it, and they will be great partners for you to collect this information. But this is basically just aggregate information on SDOH screening. And if the caregiver was screen positive, then you will tell us how many of them screen positive and how many of them were referred to appropriate resources. And if you are not collecting that currently, you can just use the box unknown for that. Okay, so that's all for the patient level data. Let me go to the chat box because I think there were a couple additional questions so I can address them before we move on to the hospital level data. So the first one says, if we have a patient born in October and discharged in February, are they included, or we need to start with patients born after January 1st? No, we're basing everything on date of discharge. So you will include them because they will be discharged in February. That will be part of your February data set. Marisa asked, if we have several less than 750 grams and may have 5 per quarter, some quarters but not others, should we include the data or for the quarters that we have 5? Yes. So if you have at least 5 per quarter and you have not opted out of that category, just submit as many as you have monthly. So if you have 1, you submit 1 in that month, and if you don't have any in the next month, then you just don't submit any. It says 5, up to 5, or as many as you have. Is that form in the toolbox? The data collection form, yes, it's in the toolbox, and I will also send it to you after the webinar, so you can have it in your email as well. The next one says, demographics ask for primary caregiver, race, and ethnicity. Will those infants being adopted be included? Primary caregiver, not birth parent. Yes. So we intentionally use primary caregiver for those situations because we know that some of them will be adopted. Some of them will even go with foster families. So for those scenarios, yes, we ask you to submit that information for the primary caregiver and not the birth parent. The next one is the eligible infants referring to all infants and not the 5 from each category? So eligible infants is the first step to preparing your data, right? So before you even do the categories, or you can do the categories, but then you need to take out those that don't have at least 2 days of stay and that were not discharged home. So the eligible infants is going to reduce the number of infants in your total census for then categorizing them. Okay, where is the SDOH screening tool located? So we, as the FPQC, can provide a couple of suggestions. We don't have a specific recommendation of a tool, but we can provide a couple of examples for the screening tool. Now, we can tell you that many hospitals are already working on this, especially if your hospital is participating in the Mother Focused Care initiative. They will already have a tool in place. So connect with your maternity units first and ask them if they have started to screen for SDOH and what tool they are using. The other thing is many hospitals already have this in their EHR. Epic already has a tool there for screening for SDOH. It has been activated, and many hospitals are now using it consistently. So that would be the first step. Check what your hospital is using, or your maternity unit is using. And if they are doing none of that yet, then we can provide suggestions if you need them. Okay, and then it says, you might have mentioned this. I couldn't find the technical readiness checklist example. It's in the toolbox, but I will also send it to you as part of the data, as part of the forms that I will send to everybody after the webinar. So don't worry about it. I think in the toolbox, it may have a different name. Hopefully not. We don't mean to confuse you, but if anyhow, I will send it to you via email after the webinar. Okay, Allison asked, I wanted to clarify, we need to then also audit each chart for the eligible infants discharged home for the SDOH screening aside from the 20 charts. So no, if you don't have a way to track, if you don't have a way to track that systematically for your facility, you don't need to audit every single one of your charts. That is too much of a burden. We don't mean to make this too burdensome. If your hospital has the screening already in their system and they have a way to track it, then you will report it to us. Otherwise, you can check unknown. We don't mean to add too much burden on your plates. We know that many hospitals are already working on this or will have to start working on this because, again, this is a CMS requirement starting in January. So first check that, check if they are tracking or documenting in a standardized way that you can just get a report. And if you can do that, perfect, then you will send that to us. Otherwise, you can check unknown. Oh, perfect. And Stephanie dropped the link for the toolbox for anyone who needs it. It's in the chat box now. Okay, thank you so much for those questions. Those were great.
Estefania, I just this is Lori. I just want to add one thing about the CMS screen that is different for infants than it is for other patients, because the CMS does require the new SUH measures. They have to screen all admitted patients ages 18 and older. So even if your hospital has it in the system, they probably have screened the mother, but the infant is not required to be screened. So so if you can get the mother's information, that's probably a good way to go. But it isn't mandatory for infants. Anybody under 18 doesn't have to be screened.
Correct. Yes. That's a very good note. And one of the reasons we also ask on the eligible infants whose primary caregiver had an SDOH screening, right? So we were focusing on the primary caregiver. More than 90% of the time, that's going to be the mom. And in the few instances where it's not, we also, we're pushing for the social determinants of health screening, because regardless of the requirement, right? Regardless of the requirement, we're trying to make sure that the families have what they need when they go home. And that screening is going to give you flags of what they may need. Because if you look at the categories, it's transportation, food insecurity, housing, intimate partner violence. So it's definitely things that need to be addressed. So when the baby goes home, the baby goes to a safe place where, if we can help with any of those social determinants of health, it will reduce the family's burden and stress the first weeks when things are so difficult with a baby coming from the NICU. So, beyond the requirement, SDOH screening is a very good practice because we're making sure that we're bundling up our patients and our families to be less stressed at home. Okay, all right. I don't see any more questions for now.
Catherine has her hand raised.
Catherine, please go ahead. Sorry, I didn't see it.
Hopefully I'm not going to sound like Mickey Mouse. So here's my question on the aggregate monthly report. In the number of eligible infants discharged home, are we saying the 20 that we're submitting or the total number of discharges we have that month? I know we're doing data only on 20. I just want to clarify.
No, that's a great question, Catherine. So it would be all your patients, but we are only asking you for those that were discharged home with a minimum 2-day NICU stay.
Okay, so all of the discharges for the month, you just want to know that. Okay.
Mm-hmm.
Not the 20 that we're submitting the other data. I mean, it will include the other 20 that we're submitting that data too. Okay, got it.
Yes, absolutely. That was excellent. Okay, so for the hospital level data, we are asking to report staff education policies and guidelines, right? And this is another one of the forms that you will receive after the call that I will send to you by email. And these are just policies, that are going to help implement and support Homeward Bound. So we will ask you, do you have a procedure to administer the social determinants of health assessment tool? So again, if your hospital already is working on this or your maternity unit is working on this, this is going to be low-hanging fruit, right? And easier to do. But there is other policies, right, related to discharge. And so does your NICU have a policy to supply food vouchers and breast pumps? Do you have a strategy to provide families with a list of pediatricians who can manage NICU graduates and accept Medicaid? Do you have a policy or guideline to identify and call the primary caregiver prior to discharging the patient? So you see, those are just policies, procedures, or guidelines that are going to support the activities that we need to do to provide a better discharge for the babies. And they are meant to increase your hospital capacity, right, as the structural measures do. We do have 5 options for you to report the hospital level measures. We're going to ask you if all of those things have been started, if they are being planned, if they have started, if they have been started to implement, if they have implemented, or if they have been fully implemented. And we give you some definitions for each one of them, right? So if you said started implementing, that just means that you started to do this in the last 3 months. If it's implemented, it just means that it's less than 80% compliance after at least 3 months of implementation. So it's not routine practice, but you already have a system and you have a tool. For example, if it was to be SDOH screening, for example, you already have a tool, you are already screening for those SDOH, but it may not be done for 100% of the patients. It's less than 100, that 80% compliance. And then for the fully implemented, you have at least 80% compliance after at least 3 months of implementation. And that is what we would call routine practice, right? So you can check either one of those options for the structural measures that we just reviewed. And then for staff training, we're asking that your staff gets a process to engage the care team in coaching parents on how to do those infant care skills. So that is just providing your staff with additional skills to coach the parents. And then we also ask that your staff attends a respectful care training since October 2023, and that they commit to their respectful care practices. So last week, we shared with you the respectful care practices. That is just for you to look at what we recommend, but that can be updated, that can be adjusted for your NICU. And the request is that after your staff completes respectful care training, that they will sign that commitment. And we ask that you report the cumulative percent. So that is going to be, for nurses and for NICU providers. And this is something that you will do only every 3 months. So the first time that you will do it is in December. We will send you the link so you can send us the baseline. And we understand if everything is not started or, just planning, and this is at 0%, this is your baseline. This is something new that many of you are starting. So don't worry if the numbers are very low. We will improve from there for sure. And then we will ask for this information every 3 months. And it will be just an update of where you're at in the implementation of those processes. This is just how the form looks like. And again, I will share this with you after the webinar. Once you start submitting data, we will share with you a report. So I just wanted to share with you a couple of the graphs that we usually include in the report. This is hospital specific. So this is just going to be for your facility. What you report is just going to be a simple trend line, right? Over time, and of the percent of infants. And this is just an example, right? We may give you the percent of caregivers educated on their patient-specific care plan. And the idea here is that you can look at your progress over time, and the red line is going to be your baseline, or actually the goal, right? So we are just going to share that with you so you can track your key measures for yourself and see how much you need to do to get to your own particular goals. This is the second type of graph that we share. This is so you can compare your rate with other hospitals participating in the initiative. So this is basically a color-coded box plot. 25% of hospitals are in each one of those colors. So 25% of hospitals with the best rates are going to be in the green, and 25% of the hospitals with the worst rates are going to be in the red. So, if your hospital is the black line, this particular example is just falling right in the middle, right? But if you want to see how you're progressing, hopefully you're going to find your hospital in the green, and you're going to see progress over time, and you're going to have one of the best rates. But if you have one of the worst rates, that's okay too, because we are collaborative. We're going to learn from each other. And in every single coaching call, we're going to be sharing ideas on how to implement this huge packet. Because I completely agree with Claire. This is a lot. And we are giving it to you, and we are not intending for you to, from now to January, have everything in place and have everything implemented. We have 18 months where we are going to work as a collaborative in implementing the packet. So we are going to ask you to pick one thing first, implement it, and then pick another one and implement it, and so forth. So I know this is very overwhelming right now because we have so much in that data collection form. But again, the request is not that you implement everything at once. It's that you implement the things that are going to work best at the beginning, and then you keep on adding from the packet as the initiative goes by. So why we collect data for QI? It's just a way to inform progress and outcome of your work. It allows us to identify areas of opportunity and strength. We always use data for learning and not for judgment, only to maximize learning. And so, never feel bad if your numbers are very low, especially at the beginning, because this is new. And then over time, if you feel that you are not progressing, we can always tap on those that are doing better and get ideas and try to solve challenges together. The initial data points will be your baseline again. We ask that you review your data every month for evaluating and guiding improvement and use it to prompt discussion and action. And we also ask you to create a system that can be maintained long after the project ends, because remember, the idea of the initiative is that we're going to be working at it 18 months to implement it. But from starting now, you have to think that this needs to be sustained, because this is going to require a lot of effort. And so we don't want to lose our gains. We want to hold those gains over time. So you need to put in place a system. So this is something that keeps on going after the initiative ends. I had shared this with you last week, the QI monthly cycle. So again, you're going to start submitting data in January. You're going to get your report by the end of February, because your January data is going to be due on February. And then you're going to get your report at the end of the month. And the most important thing is that you do this other part of the cycle, right? You discuss and disseminate that data report, you identify opportunities for PDSAs, and that you attend your coaching call to share what you have, what you're doing and where you're having challenges. Again, this is our theory of change. As you have seen in the data collection forms, we are collecting information to inform every single one of the secondary key drivers. And whenever you implement something related to the packet, the idea is that you track as well how well it's improving in the key drivers, run charts, and in the data report. So we will go over that every single month. Don't worry about it. But that is the idea of collecting data for QI. It's going to be documenting how we're progressing, and if we're not progressing, identifying opportunities where we can work on. I do have a couple of important requests. The first one is that you track the completion of your hospital data user agreement. If there is any changes in your data leads, please let us know, because we have additional resources for data leads and we need to keep that updated. The first time that you're going to submit any data to us for the initiative is in December, and that is only for your hospital level data, right? Your structural measures and your staff education. So that is just going to be your baseline. If your DUA is completed, we will send you the link so you can send that to us. But then for the patient level data collection starts in January, right? So January 1st, we're going to start doing all these processes, and then your January data is going to be due on February 15th, right? And again, from now to January, you need to meet with your teams, and you need to identify those things that you're not collecting in your EHR, and you may need to start using paper forms. So come January, you can start implementing those data related items. Okay, so now that is all I have for you. This is my email, erubio1@usf.edu. Benjamin is also available for you for any questions, gessnerb@usf.edu. And we are going to be here to support you throughout. So please, if you ever have questions, reach out to us. We are more than happy to jump on a Zoom call and answer any and all the questions. So I'm going to have, again, a question section right now. So if you have any questions, please drop them in the chat box, or you can just come off mute and we will have a small discussion. So let me see. Alison asked, do you send monthly reports on the data that is submitted monthly? Or should we be creating monthly graphs? No, we send you the report monthly with the data that you submit monthly. Over time, it's really nice when you can actually work on creating internal reports, because once the initiative ends in 18 months, that's an excellent way to continue tracking your progress. But from the start, we will provide that data report. And then Catherine asks, will we be submitting data for January and February? Yes, that's correct. So your January data is due on February 15. And Heather said, how do we know if our signed data use agreement has been submitted and received? So Stephanie and Sarah, they are wonderful QI analysts. They are in charge of that process. Once your team members, all of them have committed, and that only means that everyone has responded back to their emails saying that they are in agreement and participating with the initiative, they will send the data user agreement to your email, right? And that once that data user agreement is completed, usually that is done by your initiative lead. So whoever was named as your initiative lead, that is the person who will know where that data user agreement is at. So sometimes it takes just a day because the person that is allowed to sign can just sign it. And it's a very brief process, but sometimes it has to go through other instances. So your data, your initiative lead is the person that usually drives that process. So I would recommend you that you reach out to them and ask where are they in the process of their DUA. Once that is signed in your hospitals, that is sent back to us, to FPQC, and we finish the processing of the data user agreement. As soon as that's done, you will hear from us, congratulating you for the completed process, and we will immediately send you the links. The links have not been sent yet because we do have a couple of hospitals that have completed the data user agreement already, which was very surprising, and I was so excited to see that. But they will be shared starting the first week of November. So if you already have a data user agreement completed, and you have received that congratulations email and you haven't received any links, don't worry about it. You will receive them very soon in the first week of November. But for others, as you complete your data user agreement, you will also receive your links for the data. Okay, let's see. Oh, sorry, Sarah also wrote it much, much better in the chat box. Thank you, Sarah. You're awesome. Okay. Any other questions? I think we addressed them all. If I missed any, please let me know. No questions? Okay, so I will follow up via email. I will send you all the data forms. I will send you some of the checklists that you need to complete that data form. And I will follow up as well with instructions for the sampling process. If after you review all that, you have any questions, you would like to set up a meeting with us, please email us back. We would love to meet with you. And that's all I have for you today. Thank you so very much for joining us. This is going to be a great initiative, and we are looking forward to getting it started in January. Sue, do you have any additional comments for our teams? You're muted.
Sorry about that. Just so that everybody knows, the meeting is being recorded. It will be in our toolbox. So if you have people that you need to see it and that couldn't make this, that it will be available. Also, please, please, please make sure you're on your coaching calls. Those are going to be invaluable for you. So you will be getting more information as that goes out. So I just really want to remind everybody about the coaching calls. We will be sending the dates and all of that out as it gets closer to the initiative. But right now, hopefully you're formulating your teams, you're getting things ready with your 30, 60, 90 days, because this is the time to do that process. So, and thank you, Estefania. This was a fabulous webinar.
Thank you, Sue. You'll be fantastic. This is such a group effort. Like, we have been meeting for a whole lot of months, and it's been a process, and we appreciate so much the feedback that we have received from many of you, actually, and all the questions that you have following There is one more question. I want to address it before we close. It says, do you prefer that we drop off a group if we don't have enough population, or we just can continue to submit what we have? So we only recommend that if you have less than 5, that you don't report for that group. But if you want to report, you're welcome to. So yes, if you want to report for all the groups, you're welcome to do it. Okay, I think that was the last question. Thank you so very much, everyone. Have a wonderful afternoon. We will see you very soon.